Stroke is a focal neurological deficit, which is of no other origin but cardiovascular in origin.
Depression is the leading cause of disability. Depression on its own is a persistent feeling of sadness, a persistent feeling of hopelessness.
Welcome viewers to this week's episode of Health Watch on Advent Cable Network Nigeria. I am Angela Wenze. On this week's episode, we shall discuss depression. Previously, we had a general discussion on depression, but today we will focus on depression in younger persons. By this, I mean students in the university, secondary school, those working, and so on. Let me tell you why this discussion today is important. Whether you're watching as somebody going through depression, or know somebody going through it, or you don't even know about depression. Depression has been declared by the World Health Organization as the leading cause of ill health and disability worldwide. More than 300 million people are now living with depression, an increase of more than 18% between 2005 and 2015. A study carried out by the Department of Community Health, College of Medicine at the University of Benin, Edo State, Nigeria, reported that 4 out of 10 respondents screened positive to depression and 1 in 10 had suicidal thoughts. This is similar to a study conducted by the Department of Community Health at the Ahmadu Bello University in Nigeria as well in 2018, which reported that 58.1% of students, that is about 5 out of 10 persons, screened positive to depression, although this was at varying degree of severity. That is, some people had it mild, moderate, and moderately severe. So, what is responsible for this high number of depressed young persons? How do we identify depression? Is it preventable, treatable, or avoidable? In fact, so many questions come to mind. My guest on the program today is Dr. Olusegun Soyombo, and he is a consultant psychiatrist at the National Hospital, Abuja. You're welcome to the program, sir.
Thank you, Angela.
So it's finally good to see you after I looked for you all this while, but it's good to have you here today. So I think you've listened to the introduction I just made. Does that correlate with what you see every day in the hospital, you know, with regards to depression? You know, the patient that come in to see you, I mean, every day in the hospital.
Absolutely, absolutely. Like you have said, that it's the leading cause of disability worldwide. The tragedy is that even with these figures, most of those who need treatment for depression do not have access or have an opportunity to get treatment. And the reason is that a lot of people do not necessarily identify depression as an illness. You know, when somebody has malaria and is vomiting, has a fever, when somebody gets in an accident and breaks a limb and all that, the people don't think about it. They rush the person to hospital and then they get treatment. But depression is not quite like that. A lot of people, a lot of myths around it, a lot of people will just wave it away, you know, with their hand. Oh, you are lazy, or you are just negative, and all that. So a lot of people don't get. So a lot of times there's a cry for help one way or the other, but people don't get access to treatment. So the intro quite captures it.
Yes, so somehow then all these statistics we're reeling out might not really reflect the reality of what we have, because people don't even know how to get help. That's what you...
Well, the statistics are reliable to a large extent. If there's going to be any error, it will be that we are underestimating the impact of depression. Certainly not overestimating it, because it is underreported. These studies that you've quoted are community studies, more or less, people taking a group of people and then asking questions, and then you try to extrapolate that to the general population. So it's fairly reliable, but we know that it's underreported, and we should keep in mind that in this part of the world, we do not readily confess to having emotional symptoms. Okay, so you look at all the major languages, the response to how are you is fine. Kedu, Odima, Yayajiki, Lafia, Laosha, Lafia, Alafia, and then you pick all the other languages. So people do not readily agree that they have emotional distress.
Yes. Wow. Okay. So now we know there is a problem of depression. there is a problem. So the next question that comes to mind is, what exactly is depression? You know, I can just use it carelessly as, oh my God, I feel depressed today. But I don't think that's the meaning. If this is a problem, then the meaning is not just when you're not happy.
Sure.
So what exactly is depression?
Depression is a mood disorder characterized primarily by undue sadness. Mark the word undue, or we say it's a pervasive low mood, where a person feels sad for a long period of time. And this is the kind of sadness that doesn't even respond to positive cues. So even when there are things around the person that should make the person happy, the person remains sad. Unhappy. The person remains sad. Now, we have to differentiate this from the regular sadness of, I don't have money, I've been jilted by a boyfriend or a girlfriend, I don't have food, or my team lost a football match, and things like that. Here, the key word is that it is pervasive. That means it is persistent.
Okay, so continuous. It happens.
It is continuous.
Okay.
So for most times of the day, for a period of 2 weeks or more, the person would have been feeling sad. Even when things to make the person happy occur, the person is not happy. You also have low energy, where a person feels sick, feels weak. Like, the things you do every day effortlessly become a big task. For example, people who are depressed may find it difficult getting out of bed in the morning. They may find it difficult taking a shower, changing their clothes, going to work, and all that. Now, when you look at all of this, you see reasons why they may not have access to treatment, because these are things that people can explain away. Oh, he's lazy. He doesn't want to do anything. So you find these people feeling sick, and then in our environment, they go from hospital to hospital saying, oh, I'm weak, I'm weak, I'm weak, I'm weak. And then they get treated for typhoid and malaria, that doesn't go away. So we've talked about low mood, we've talked about low energy. There's also loss of interest in pleasurable activities. So you find a depressed person, the things they used to take joy in, they no longer derive pleasure from those things, or they no longer do those things. So for example, somebody who used to love to read or hang out with friends, watch movies, listen to music, no longer derives pleasure from any of those things, and then stops doing them. So those are the three core symptoms: low mood, low energy, loss of interest. Of course, there are a lot of other associated symptoms. There might be a poor appetite, or in some cases, really, increase in appetite. Some people, when they feel sad, they take solace in food. But what we have more commonly is a loss of appetite. So, consequently, of course, there will be a weight loss for the person. Poor sleep. People who are depressed can have difficulty sleeping. It might be initiating sleep. More commonly, they have a problem staying asleep. So they sleep, they wake up, and then they are awake from 2 a.m., 3 a.m. in the morning. They cannot go back to sleep. They have all these negative thoughts going on and on in their minds and things like that.
This sleep one, because I'm trying to think of myself. So this sleep one. So if you're not sleeping well, it means you must consider the other factors you have reeled out, which is the mood. That is, you don't like doing the things you've always liked to do.
Yeah. So
loss of
listeners,
energy.
our viewers must be careful not to take these things out of context. It is not everybody who doesn't sleep well that is depressed. It is not everybody who has a poor appetite that is depressed. It's a combination of symptoms that have persisted for a period of time, and that's why diagnosis is done by professionals, people who are trained to make diagnosis. So people may use the word loosely on the street, but depression is a specific diagnosis that is made clinically. It's not something somebody just slams a label on another person on the street and say, you know what, you are depressed, or you know what, I'm depressed, and all that. No, there are guidelines for making the diagnosis.
So the people that are going through this stage, do they have the ability to know that there's a problem? Because how I'm asking this question is, if you're sad consistently, maybe there's somebody watching and has been sad consistently, is it within a period of time then you start knowing that, look, I've actually reached the mark? Maybe you've been sad for 3 days. Will you now say, okay, I need to check in and go and find out if something is wrong with me?
Well,
what's the period you're looking at?
Well, technically, to make a diagnosis, symptoms must have been present for a minimum of 2 weeks.
So you have been sad consistently
for a period of 2 weeks or more. However, when people are sad, they don't keep counting the days to say, okay, this is day 1, this is day 2, and then when they reach 2 weeks, they say, aha, this is 2 weeks that they talked about on ACNNTV. Let me now go to the hospital. No, people will not necessarily
Okay, do it that way, yeah.
But remember that when people come to clinical attention or when people are brought to hospital, we are examining behavior in terms of a change from previous functioning.
Okay.
So the person has not always been
like
that.
Okay.
So something has changed. So the person may not know that he or she is depressed, but he knows that I've been in a better place, I've felt better with myself, I've felt happier within myself in the past. This is a change. So apart from the person knowing, okay, which we call a subjective feeling of depression, there also in some cases might be evidences from people around who will say, oh, Mr. AA used to like to hang around with us, so he no longer comes to hang around. Oh, we've noticed these days that it's always looking gloomy. Sometimes what will prompt somebody to go to hospital might be several people coming to say, oh, what's the problem? Cheer up. What's the problem now? Okay, talk to me. What, you know? And so you see that other people have also noticed that person has been in a bad mood.
In a bad mood. All right. So now the loss of energy, I'm trying to understand when somebody says you lose energy, no desire to, maybe you normally go to work at say 7 in the morning or 8. Then this day you just can't lift yourself out of bed and all that. Would that be it? Do you get body temperature or
no, your temperature might not be part of it, but
okay.
A low energy, you know, it's a feeling of weakness that is within. It's not something you can measure on the outside.
Right,
so if somebody says I feel weak, the person feels weak. There's nothing you will see. In fact, usually to the contrary, the unskilled observer will say, but there's nothing wrong with you. That's why I had to make that distinction. I had to clarify that people will often dismiss them as being lazy. But this person has been going to work before and he goes early. All of a sudden he struggles to get out of bed. The usual things, he struggles to read. It's both a mental and physical tiredness that the person feels. So when you begin to have a depressed person having difficulties at work, he cannot concentrate, he cannot complete tasks. All those are consequences of both the mental and the physical fatigue that person is feeling, which is what we describe as a low energy.
All right. Then it comes with other things like you don't feel like eating anymore, or some people might be eating more and all that. Okay, because I just wanted the clarity, just in case somebody's watching and noticing something like that. Now, there was a study I saw, and it says that women had depression more, or there were more women that were coming down with depression than men. Now, I don't know if that is, well, I hope it's true. I don't know if it's true or not. But if it is, why would women be, is it choosing the gender to attack, or I don't think that's the word to use?
Well, I don't think it's about depression or choosing a gender to attack. First and foremost, statistics is what it is. You go and find something, you report what you find. And across several places, studies have shown that depression is in fact twice as common in women as it is in men. However,
twice as common. That's a whole lot.
Yes. For every one man that comes down with depression, you find two women. So we've tried to find explanations for this. Some have argued, for example, that men bottle up feelings and they may not come out to ask for help. So maybe we are not catching as many men having depression.
More like
it sounds a plausible explanation, but when we get to the point of talking about the things that cause depression, you will see that there are quite a number of predisposing factors that affect women because of their gender. For example, some people have depression after giving birth. Men don't get pregnant and give birth. For example, there's also a study, very prominent study, that has shown that staying at home, taking care of young children is a risk factor for depression. But the men go to work.
And mix with all people.
Mix with other people. The woman stays at home. She doesn't close. Staying at home is not 8 to 4. You stay at home, prepare children for school, they go to school, you clean up after them, you pick them from school, they come back, they have lunch and all that, their father comes back, and then the cycle continues and all that. That's another risk factor. When we come to the issue of domestic violence, physical and sexual abuse, of which women suffer much more than men, So when you put all these risk factors, you begin to understand, and of course hormonal factors also. So you begin to understand why indeed it may be true that depression is twice as common in women as it is in men.
Wow. Now, I think I'm learning too much today, so much today about depression. But we're going to go on a quick break. When we return, we'll talk more about the causes of depression. So when we return, we'll talk more on the causes of depression. We'll be right back. Welcome back, viewers. Before we went on the break, we were discussing depression, and we've just gone through understanding what depression is. And my guest is still Dr. Olusegun Shoyinbo. He is a consultant psychiatrist at the National Hospital, Abuja. So thank you very much for that, but we still, still have a few more questions. Now, the causes of depression. Or before I ask about the causes, there's always this thing people say when you feel depressed, just it's a state of mind, just think positively, do the right thing, and it will just fly away. I've actually heard people, even like in the churches, preach about it. Just think positive. You think positively, if you do the right thing, you won't be depressed. Does that, from your experience, does that make any sense?
No, it doesn't. It doesn't.
Okay.
It's in fact the reason why many people don't come forward for treatment, because they think then that if they come out and say they are depressed, people will see them as being weak, being negative, not having faith, and things like that. So a lot of people hide because they do not want to be stigmatized. Depression is an illness. It has a biological basis. We can explain what we call the neurochemistry of depression that has to do with certain chemicals in the brain. Because when we give medications to treat depression, what we are all trained is the balance of certain chemicals. In fact, the chemical is altered. That's why the person is depressed. And then we're giving medications to correct that alteration. So when people say, oh, come off it, think positively, do the right thing, it's completely wrong. When a woman is pregnant and is vomiting, do you say to her, stop vomiting?
And think positively.
When somebody has malaria and has a fever, do you say, what's wrong with you? Why is your body hot? Stop having fever. So the symptoms of depression are symptoms of an illness. It's out of the... No, I mean, if a person could control it, who would want to feel that bad?
Yes.
So it's absolute nonsense. There's no truth in it.
So just to reiterate that, it's like, people, there's this issue of stigmatizing people who are depressed and labeling them. But that is wrong, because you wouldn't label somebody who has malaria, who says, oh, malaria. They go and take medication. So we should see that way. When you see that kind of thing, it's an illness, that requires treatment. So don't stigmatize the person. It's an illness, it requires treatment. Okay, that's an excellent point to take. So now, causes, because every illness has a cause, or what is responsible for it. So why would somebody get depressed, like, be ill with malaria? What are the causes?
Now, discussing the cause of depression is not such a straightforward business, but we'll try and make it simple. Let us first identify that there are what we call biological causes, psychological, and social. More or less, we call them predisposition. Predisposition means that you have this because you already had that. Remember in university they say one course is a prerequisite course. It means if you don't do it, you can't do another one. So predisposition is like prerequisite. It's like it is because of these certain predispositions that a person is more likely to have depression than another person. So we start first from the biological causes.
The biological causes.
Yes. So there are genetic factors. When people have high blood pressure, when people have diabetes, and you go to hospital, the doctor is going to ask you, does your father have it? Oh, did your mother have it? Is there anybody in your family that has had this type of condition? What they are trying to establish is a genetic linkage. Because the closer you are genetically, the more likely that you may have what another person in that lineage has had. I hope I'm explaining it in a simple way. So genetic factors. So people who have close relatives who have had a depressive illness, for example, are more prone than others who do not have such connection
and
to
this
have
is
depression.
the first time I'm hearing this anywhere, that it's genetically linked.
it is genetically linked.
Okay.
Now, it is not invariable that once somebody has it in your family, you will have it.
Okay, okay.
So again, we have to be careful.
All right.
Because when we want to get married, they say go and investigate that family.
Yes.
Whether there's anything in their family. And I don't know which family does not have anything.
Okay.
Okay. So they say go and investigate. So we have, it's not invariable. So that's why somebody may have depression and all his children may not have depression.
Okay.
And if one of the children has it, the question is, why didn't the other three have it? Okay. So genetic predisposition. And the closer the genetic link, the higher the risk. The risk as it is for other illnesses. Yes, it's not peculiar to depression. Also, we talk about certain things that might happen. Remember, the brain is what we are talking about because it is that's the seat of our emotions that controls our behavior and all of those things, you know. So if somebody maybe in the process while a woman was pregnant, there was an insult, an illness during that pregnancy that was severe to affect brain development, or maybe when they were giving birth to the child, they had some trauma. A lot of things that can happen that might have affected the brain may also biologically predispose the person to a medical illness, to depression.
To the depression,
Now, there are other illnesses. Depression is associated, is higher, the prevalence, the risk of having depression is higher in people with certain other chronic medical conditions. For example, people with chronic pain conditions, low back pain, people with diabetes, okay? If somebody has a diagnosis of cancer or some other illnesses, they are more likely to have depression than the general.
Is it depression? Because I know
population.
the WHO would have said that it's the leading cause of disability, and sometimes when you think of it, you're wondering if it's the leading cause, then it has an undertone in almost every kind of ailment. So is it this, like when you're talking about the diabetes, is it the diabetes that would have made predisposed somebody to depression, or depression is the underlying factor that makes? I don't know if you understand what I'm trying to drive at.
I understand what you are driving at, and it's a brilliant question, because in fact studies have shown we are almost at a point where we can say that perhaps the gene that is responsible for people having diabetes may be the one responsible for people having depression. Because you can have depression in up to 60–70% of patients who have diabetes, but there are many things that may be responsible for that. It might be the gene, for example, but it might also be the response to the news of the diagnosis. Nobody likes to have a chronic illness. You suddenly now cannot drink this, cannot eat that and all that, and then you are having to test yourself every now and then, and then some people have side effects, some people to control it is difficult. So just take it as chronic ill health. So depression predisposes people to chronic ill health, and people with chronic ill health are also more likely to have depression. It's a two-way relationship. Not to dwell on biological causes, because importantly we have to talk about psychological and social causes of depression, because the environment affects us. So if a person is depressed in 2020, the question is, why wasn't he depressed in 1990? Why wasn't he depressed in the year 2000? Because there are environmental factors also. So we are living in an era of increasing urbanization, social isolation. People are not having as much face-to-face interactions. Nobody cares about the other person, the communal support and living that we used to have. We're losing it fast and things like that. So all those things contribute. Of course, loss events can trigger episodes of depression in people. So losing a loved one, death, for example. But death is not the only loss event that can cause depression. Divorce, which we are seeing in alarming rates. Loss of employment, loss of social status, and things like that are things that can also trigger episodes of depression. So it's for some people, you might find one major event in their life and say, this is why this person is depressed. For some other people, it might be multiple small events that will give a cumulative effect, and then the person will have depression. So there's no direct answer to say, oh, it is this thing that causes depression. We just have to bear in mind that There are genetic predispositions, other biological causes, psychological and social causes of depression.
Wow, that's a lot to take in and findings right now. So now, is it somebody who is, have you ever had a patient come into the hospital and say, I think I'm getting depressed? Or how does it happen? What's your experience like? Do people come by themselves, or somebody brings them in, or somebody tells you, look, I think there's something wrong with this person? How has been the experience with you?
It's varied.
Okay.
Certainly some people come in by themselves to say, look, I don't like how I'm feeling, and I want to be evaluated. Oh, I think I'm depressed. Yes, we've got a few people who come in like that. For some other people, they'll be brought in by friends or relations, who are worried about them and think that they should get help. People have come in for evaluation after watching programs like this, or after listening to health talk somewhere, and then they could identify with some of the symptoms that the speakers talked about, and then they will come forward for, for assessment. Sometimes people come referred by other doctors. Remember that we talked about low energy levels, and we said that people can feel sick and go from hospital to hospital. At some point, if fortunately they come across a doctor with a high index of suspicion who says, you know what, you've been going all around and you've been having all sorts of evaluations, all your tests have come out normal, perhaps we should check your emotional well-being. Ask a few questions and then says, you know what, I think you should see a psychiatrist for further evaluation. So that's also another route that people come forward through. So different ways really by which people come forward.
Okay, now I want to go to the young people, because we talked divorce, we talked about, issues that would have losses and all that. But now for younger people, say those in secondary school, because I was surprised to hear that people in secondary school are depressed, and I'm wondering, what exactly are you depressed about? Maybe that's just me being a normal person, So why would a young person in secondary school, be depressed? Well, okay, we talked about the whole chemical imbalance and all that, but, it's difficult to get it off your mind that, look, you need to do something. But a younger person, maybe a younger person watching, what are the things that predisposes a younger person to depression?
Yes, thank you very much. The same factors that we have talked about, maybe in different ways, will play out in younger persons.
Okay.
Genetic predisposition is there, irrespective of age.
Of
For
course.
the person that will have it, it's a matter of when the person will have it. But we'll come to talk about these younger persons. We'll look first at their social environment. For example, somebody suffers physical abuse, sexual abuse, emotional abuse. Oh, even the boys too.
Oh, yeah. Oh, okay.
Even the boys too. Emotional abuse. They may get depressed. They may get depressed. If somebody is not doing well in his academic pursuits, the person is in school, she's failing exams, she may get depressed. Now, the point to note is that not everybody who fails exams will get depressed.
You get depressed, of course.
Okay.
Yes.
We should also note that somebody who's been doing well and suddenly is not doing well, it might be the depression that is now making the person not to do well. So you've got to think about it both ways. You fail exam, you get depressed. You get depressed, you fail exams. It can happen both. It can happen both ways. And then you look at the general environment that we live in. Again, talking about social isolation, poor support, increasing cases of violence, bullying. Bullying. You cannot talk about depression in young people without talking about bullying
in school,
which goes on a lot. So which is
school.
something that we have to pay a lot more attention to, because not everybody has the resilience to withstand the bullying or to withstand whatever negative events go on around them. That's why not everybody who goes through the same stress would turn out the same way.
Okay.
You understand? So some people will go through it, they'll be fine. But for a few people, a few others, perhaps who already have other vulnerabilities. So you put two children in the same school. This one has a family history of depression. This one doesn't have a family history of depression. This one, that both of them suffer the same kind of bullying. This is the one who is likely to break down earlier than the other person. So all those other factors come into play.
You know, I'm just thinking, I'm just wishing there are teachers watching, because
I'm sure they are.
They are. Yes, yes, they should be watching, because when we come back now, we're going to go on a quick break. But when we come back, I want us to talk about things parents can look out for, teachers can look out for, even members in churches can look out for, pastors can look out for, and there's so many things we'll talk about. But when we come back from the break, we'll talk about them.
Sure.
So we'll be right back. Welcome to this segment on Health Watch. Today we shall be learning a few things about sleep. Getting enough sleep every night is crucial for human health. It is not a luxury, but something we'll all need for good health. I could not find any study on the number of persons in Nigeria who are not getting enough sleep, but some medical professionals are screaming that the number is on the rise every day. I saw a study by the Obafemi Awolowo University Teaching Hospital that reported that 7 out of 10 patients presented to its family unit had some form of sleep disorder. Furthermore, another study in Lagos, Nigeria, reported that children in Nigeria had shorter sleep duration and more sleep problems than children in other countries. This, I think, is quite disturbing. Now, what is sleep? I know you just sleep and might not really know what sleep really is. There was a time when people thought that sleep was simply a time when the body and brain shut off for a few hours each night to rest in preparation for the next day. But now scientists understand that neither the body nor the brain shuts down when we sleep. In fact, they are often working even harder than they do during the day. They are undergoing processes to restore cells, process information, and improve your health. That is why it has been discovered that not getting enough sleep is linked to many chronic diseases and conditions. Now look at this, such as weight gain, weakened immune system, hypertension, heart disease, diabetes, memory loss, stroke, depression that threatens human health. Lack of sleep has also led to motor vehicle crashes and mistakes at work, which caused a lot of injury and disability. Let's look at what happens when we sleep. Even though the exact reason for sleeping is not well known, some research have been done by monitoring the brain of a sleeping person. Now, number one, it offers the body a chance to recover from wear and tear of daily life. Many studies have suggested that there is restoration taking place when one is asleep. This means that the body does not just knock off when we are asleep. Rather, the cells of the body are busy regenerating themselves. You can actually notice it yourself. After a long night or even afternoon sleep, there is this feeling of refreshment you have. Even your skin or countenance brightens. Yes, this is because your body has been working while you were sleeping. Number two, it facilitates learning and memory. After you've had a very good sleep, you notice that you're able to concentrate more and pay better attention. I know this for fact from personal experience. Whenever I want to study, I concentrate better, even understand better after a good sleep. Interestingly, I saw a study by the Harvard Division of Sleep Medicine, and it suggests that sleep is a time for the brain to consolidate memories, which makes learning new things easier. For example, people who sleep after learning how to maybe play a video game or how to play an instrument generally perform much better in the game or instrument later than those who stay awake. Number three, it plays a role in immune function. Your body produces special proteins which help your immune system fight off infection. So while you are asleep, there is a complex network of activities between the brain and the immune system to help you fight infection. This may be the reason you sleep more or feel the need to be confined when you are ill. Your body needs your sleep to perform its function. Have you noticed that when you get to the hospital, there is a time marked out for visiting sick patients? This is one of the reasons. The hospital wants the patient to have enough time to sleep, especially the REM sleep, or what we generally call the deep sleep, so as to allow the body work with all the infusion it has received. So next time you visit the hospital, find out about their times of visitation and please respect the time. You may be visiting your ward who is recovered, but his bedside neighbor may need more sleep to recover. So sleep gives the body the time it needs to produce these infection-fighting proteins and to restore itself to wellness. In the next episode, I will continue our talk on sleep. We will learn how long we need to sleep each night and how we can get good sleep. Let's get back to the concluding part of the program. Welcome back. Before we went on the break, we're still discussing depression, and we have talked about the causes of depression. And I really hope people or those watching or anybody watching is getting something from this discussion today. I still have my guest, Dr. Olusegun Cheyonbo, program. So now we want to, just before we went, I was talking about teachers,
what to look out for.
Teachers, parents to look out for, even pastors in churches, because I realized that people tend to run to their pastors. Once something is wrong with them, they quickly go to the pastor. If it's in school, the students go to the teacher. And if it's at home, well, I hope kids go to the parents if it's at home. So what should they be looking out for, you know, in their words?
The important message here, first of all, is that it is everybody's business.
Okay, it is everybody's business. Okay.
We all have to look out for our friends, our brothers, our sisters, our parents, our children. We all have to be vigilant, okay? So important things to look out for would be a change in the person's behavior. All the things that we've mentioned. If we want to calm down on younger people, they may not exactly say they are sad. Okay. They may not exactly come out and say that they are unhappy. But you might notice, for example, that they become irritable. Right. Get angry very easily.
I was just going to ask about that, become violent.
Pick fights over little issues, okay? You may find out that they begin to try to cope with these things that they don't understand, and then they are trying to cope with it in maladaptive ways. So they may take to substance use. They may start drinking, they may start smoking things, they may just change their friends and be moving with bad gangs because they just think that, oh, when I do this, it lifts my mood, it makes me feel better and things like that. So you see things like that. So it changes in sleep, changes in academic performance, crying a lot without reason. When you just see people crying, you just come out, you see the young girl coming out of her room and then she's trying to rub her eyes, or she's going to wash her face so that nobody knows that she's crying and things like that. So those subtle things are the things that parents need to look out for. And sometimes they will come out openly to say, I don't know what's wrong with me, I don't feel good, I don't feel happy. It's a delicate balance, because first thing the parent is concerned about is this bad behavior.
Yeah, that's what I was thinking about, the drinking one.
This laziness. Oh, you are not reading your book. Oh, you did not even wash your plate. Oh, your room is untidy and all that. The important thing is, how has this person been over the years? So if there's a change, then you might need to evaluate further.
Okay, so which means when parents are looking at their kids, if what they used to love to do before, they start doing, and not every time a child starts following bad gang means they are just sports or they become naughty.
Yes. Sometimes people are trying to cope. Even adults. For example, we talked about poor sleep. A lot of people, when they cannot sleep as a result of their low mood and depressive symptoms that they have, a lot of times before they even come to clinical attention, they would have tried to sort out the sleep problem through other means. They take things that they think will help them sleep. But you see, it doesn't solve the primary problem, doesn't solve the primary cause, you know, so that's it.
So talk me through how somebody will come to the hospital to present a case. You know, because when you talk about psychiatrists, everybody should go and say, psychiatrists, am I mad? You know, unfortunately, so this is not, but this is how it is, unfortunately. But if you tell somebody, they think they want to hear, okay, take me somewhere to a therapist or something like that. But how do they come to the hospital? Do they just come normally and take a card, or how do they come in to present their case?
Yeah, like I explained the other time, people coming through different pathways, but the very first issue I would like to address is how people respond when they are told to go and see a psychiatrist.
Thank you.
People shouldn't worry so much about that. Nobody calls anybody. Who is a mad person? What's the definition of madness? We have said depression is an illness, as there are other mental illnesses. And then it is in the purview of psychiatrists to make the diagnosis and treat people for mental illnesses. Not psychiatrists alone. We work with other people. We work with psychologists, we work with nurses, we work with social workers, we work with occupational therapists. But the doctor that you will see to make a diagnosis of a mental illness and treat it is the psychiatrist. So even when your general practitioner thinks that there's a problem, he's been able to make a diagnosis, if he feels that you need further care, it's just being a responsible doctor by sending you to the place where he thinks you'll get better care. Now, when people say, oh, I'm not mad, you know, again, another problem is the depiction of mental illness in the media. When we want to act on video and want to say somebody has mental illness, we'll wear him rag. We'll tie can around his body. There used to be a movie when I was growing up, Morenike Alagolo. The woman was tying all sorts of used cans on her body, and then she was dancing on the street, and children were following her, and everybody was. So that's the depiction of mental illness that people see, and that's why they say, am I mad? Now, the truth is that people get to that stage because nobody, or they did not have access to treatment. If you bring some of those people to treatment, you will not know them again in about a week. So people shouldn't feel bad when they are told to go to a psychiatric hospital or a psychiatric department. If they come to our department, for example, they will see fine young men and women who go to work, who are married, who live their lives normally. So talking about how people...
Thank you for clearing that, because it's very important.
So talking about how people come to hospital, if you feel bad, you experience any of these symptoms. And in fact, may I add that in severe cases, people may also have other strange experiences. They may hear voices that other people don't hear. They may see things that people don't see. They may have undue feelings of guilt that they've done wrong. They may feel worthless, feel hopeless, and particularly begin to have thoughts of killing yourself, harming yourself. Please go to the nearest hospital. You do not necessarily have to walk straight if you do not know where to find a psychiatrist. Go and see your general practitioner. They will point you in the right direction to go. Now, for people who are undergoing difficult moments, marriage difficulties, difficulties in school and all that, they may not exactly feel like they are depressed. But whatever problem you have, talk to a responsible adult. Responsible adult could be your teacher, your counselor, your pastor, your religious oversight. Whoever that responsible adult is, share with them, and then they can point you in the right direction. Remember, for example, we mentioned that divorce is a loss event. But we know that people who get married in the church do premarital counseling. And then we get them married and we leave them alone. To divorce, you must be married. You must be married, of course. So there has to be concerted effort to let people stay married. So what form of counseling, what form of support do people continue to get in marriage? Or do we assume that the premarital counseling we've done is enough to last people for 50 years and 60? Obviously not. So people need to continue to get support. We go to our young people in their schools. They need counseling, they need help. Course advisors should do their work. By the time somebody feels out of school, there's failure on many fronts. There's failure on many fronts because somebody should have picked it at a stage that this person is struggling. How can we help? What is the problem? And all that. So there are so many interventions. You come to the economic side of it, where people say, oh, it's because there's no money. Well, government is not going to be dashing people money, but we can help people walk through difficult times and all that. And those are important points.
So there's a lot more that you can get from a psychiatrist as opposed to just thinking the wrong impression. And I'm really glad that was, because when you think, honestly, I don't know if you have we had a program and we invited the psychiatrist and he came, and somebody told me, this is the first time I'm actually seeing, in his mind, he just didn't have a picture of who a psychiatrist is. I said, but look, can you see him? He said, I don't know, just the way.
I hope I'm showing you where I am and I don't have one on my head.
Yeah, exactly, because so let everybody know that, look, these are doctors you're going to meet that will help you in trouble. Now, I want to go back to the pastor issue. I know there are lots of them even watching now. When people come to them, can you just talk to our pastors on what they can do? Because many people will go to them and tell them, this is my problem. And maybe they will put them on days of fasting, or, do this, you need to pray, read your Bible more, you need to do this. Can you just talk to the pastor? I'm sure it will help a lot of pastors.
I'm grateful for this opportunity.
Yes, very important, because
talk to pastors and the general public. In fact, the first thing I want to say is that medicine and faith are not in competition.
Okay.
I say that to my patients all the time. I'm not in competition with your pastor. In fact, your spiritual oversight is superior. I concede that they are superior. Why? Because your pastor can pray on a picture. Your pastor can write name on a paper and pray on it. You can go to your pastor and say, my brother is in America, is depressed, and I say, I pray for him to receive healing in Jesus' name, and healing can happen. That's superior. I cannot treat you unless I see you. Okay? So we are not in competition, and we can work together to achieve the same thing. So we do not discountenance people's religious beliefs. However, they should recognize that depression is an illness, and then there are other mental illnesses that have science-proven treatment. Why don't people go to their pastors when they break a leg in an accident? Yes. At least not immediately.
Not immediately, yeah.
You will first go for first aid.
Yes, your first aid and get it, of course.
And all that. So it's an illness. People should take the treatment. So the pastors should help us point them in the right direction. Now, because these are deep-seated emotional and private issues, people are likely to feel more comfortable talking to a person like their pastor. Okay? So when the pastor gives that listening here, and then for a pastor who has watched this kind of program, and for pastors, I think they should generally educate themselves, find means of educating themselves about emotional problems and mental health disorders, so that they can point people in the right direction. You can support them with prayer. A person is not depressed because he lacks faith. A person is not depressed because he has committed sin. And all that, so the person has an illness. Let us support him with prayer, but let us point him in the right direction. Okay. I say to people, do you know pastors who wear glasses? That's medication.
Yeah, of course.
Why can't the pastor, through his faith, throw away his glasses? There might be those who have done it, but we cannot put God in a box and expect him to work the same way for everybody. So it works in diverse ways for us. So if you take a drug and you get well, that's a miracle on its own. It's not everybody that takes medications that gets well. So people don't have to wait for that extraordinary, mind-blowing miracle to say, oh, I received my healing, I threw all my medications. No, it's not necessary. It's not necessary. So the pastors can really help us point people in the right direction.
So, and I believe they're listening. So if a patient comes to you, with presenting this symptoms, even if it's not clear, just send them to have a check, and then I'm sure they will get help.
And importantly also, we do not cut. And when we talk about pastors, we are saying pastors because we're in ACNN.
It's also,
religious oversight generally. The imam, whatever the person believes in, and whether it is religious oversight. Because if a patient comes depressed, for example, and one of the stressors around the patient is marital disharmony, that's a place where the pastor can come in. You can let the doctor take care of the depression, but you may be the one to sort out the marital disharmony. Because I tell people, there is no drug that makes people happy. If there was, I would be the first to be taking the drug. So we can give you the drug and treat the depression, but we've got to address the issues that make you unhappy. Is this person unemployed? Can we help with skill acquisition that will help him have some income? Can we counsel the wife or the mother or the husband or the so that the situation at home is better?
Is better.
As this person taking some wrong decisions, can we help him walk through how to get back on the right path and not make the same mistakes in future? So there are several ways that religious oversight can still come in and help people who are depressed. But by all means, they should point them in the direction of treatment. They shouldn't make them feel that they are depressed because they lack faith. Or because they are weak. We don't tell people who have malaria. I mean, pastors also have malaria.
Of course.
And at that time, it's not faith. You simply take your anti-malaria and then you get better. So it's an illness just like that.
Just like that. So now, you know, before we started, I talked about a friend who committed suicide, and I know one of the things I noticed about him was the complaining, you know, and me being insensitive, you know, I didn't, maybe if I had known better, maybe I would have said, okay, I think you need help, because he kept on complaining, and anytime you meet him, he's complaining about the country, he's complaining about something, and I felt, look, I'm not in the same country, why are you just complaining? Now, others like us, you know, friends, family, who are just members or just friends, what do you advise us to do when people come with this kind of thing? Because I really felt bad that period, because I know he complained a lot to me, and I felt, sometimes I was even running away from myself. This guy's coming with his complaint again.
Remember, I said that it is everybody's business.
It is everybody's business.
It is everybody's business. Because not only do we treat depressed people, it affects their relationships. It affects the people around them. People can be devastated when their friend or family commits suicide. The person who has committed suicide is gone.
Yeah.
And then some people remain and they are devastated and they are dealing with their own issues. Okay? So we have to be sensitive to people's call for help. People may be crying for help. So, you know, certain things that we take for granted. I will kill myself. You've been saying these things since. You want to kill yourself, kill yourself. No.
Don't take
the person don't take it for granted. The person may actually mean it. The person might have been harboring that thought, and somebody needs to come with empathy, you know, and give listening ears and say, this thing that you say, what's the problem? Do you really mean it? Should we go together? So one of the ways to help people might be to take them to hospital. Remember, we said that it's low energy, and doing everyday things might become difficult, like going to hospital. So the person might just need somebody to take him or her by hand and say, let us go and see the doctor.
That may require a lot of patience and love and concern.
Absolutely, and isn't that what the Bible commands us to do? That we should love our neighbor as ourselves. So that love is what propels us to help them and say, let's go. Okay? Somebody feels depressed, but she has 3 children, and she's not going to leave them and go to the hospital. Somebody might offer, I'm going to babysit for you. I'm going to look after your children. Go with sister so to the hospital. Go and talk to the doctor. You are not the one to say she's depressed. Just go and talk to the doctor. Let them see if they are able to help you. Okay? So we've got to give listening here. Sorry about your friend. Okay? The tendency is to dismiss people's complaints, you know, explain it away. Oh, this country is hard for everybody
not just
and
you.
all that. But you see, the depressed person looks at the world through dark lenses. Everything is bleak. He thinks about himself, there's no future. He thinks about the country, there's no future. He thinks about the world, there's no hope anywhere. So all he sees is negativity, negativity, negativity. Even in positive things. I'll give you an example. A depressed person passes an exam. What is he going to say? This lecturer just decided to pass all of us. He will not. He cannot even give himself credit for passing an exam. But if he fails an exam, what does he say? You see, I'm useless. Even this exam that every other person passed, I cannot.
It's not just that the person is negative; he might just be having a problem.
So the person might just be depressed. Okay. So sometimes it's difficult for people to identify, but it's better to err on the side of caution.
Yes.
If you think that a person is deeply unhappy, deeply dissatisfied with life, it might be important to get the person professional help.
We don't run out of time. and there's a whole lot I wanted to talk about, but Dr. Shoyinbo, you have to come back to this program again.
I'll be
And
happy
then maybe
to.
we'll talk about anxiety, we'll talk about suicide, we'll talk about so many other things.
That's why I told you that day, no, but stick to depression.
Let's stick to depression because
If
you can't
you
even take
pick
that
things,
off.
you won't
Yeah,
do
you'll be able to
justice
complete it, yes. But thank you so much for coming on the program. I know so many people that are watching have really learned a lot, but we're going to be looking out for your face more and more to really educate us this way, because this was really broken down and it actually makes a lot of sense to me. Thank you so much for coming on the program. So, viewers, for the past few minutes, I've been speaking with Dr. Olusegun Shoyinbo, and we talked today on depression. He said a whole lot of things. I don't know if I can start running through all of them, but I know you have listened and learned. But what I'm taking away today is we all need to show concern for each other or to each other. And just as he said, depression is everybody's business. It's not just the sick person's business, not just the doctor's business, it's everybody's business. So look out for each other and help each other. And help people. When you see people, look out to help them. Thank you so much for watching the program today. I'm Angela Wens. I'll see you next week. Goodbye.